Well, welcome everybody to Optometric Education Consultants National Webinar Series, the Tuesday edition. It's my great honor and privilege and fortune to introduce Dr. Joseph Shovlin, who is a senior optometrist at the Northeastern Eye Institute in Scranton, Pennsylvania. He's alumni of the Pennsylvania College of Optometry, where he is an adjunct faculty. He's a distinguished practitioner of the National Academy of Practice, diplomate and past chair of the section on corneal contact lens and refractive technologies in the American Academy of Optometry. He's a past chair of the contact lens and corneal section of the American Optometric Association, and he is a diplomate of the American Board of Optometry. He's an associate clinical editor of Review of Optometry, which is, I would say, arguably the most well-read, most widely read journal that we have in optometry. He's a past president of the American Academy of Optometry. He's been on several committees within the Academy, including the Continuing Education Committee, the Leadership Committee, and the Board of Directors of the Optometric Foundation. He's had numerous awards. He is the Albert Pitcher Memorial Alumni of the Year for Salish University. He has also received the Presidential Medal for Salish University in 2019 after the centennial celebration, and recently been awarded the Frank Fontana Lifetime Achievement Award by WebMD in 2020. So with that, please give me a nice virtual welcome to Dr. Joe Shovlin.
Thanks, Joe. Thanks, Greg. Thanks, Vanessa. Great to be with you. Am I projecting okay? You guys hear me okay?
Yes.
Good. Okay.
Awesome.
So here's our brief outline. We'll start in the front of the eye and work our way back. And we probably should insert, I think, on the COPE approval, it says life-threatening signs and symptoms. I inserted eye signs and symptoms because this is an eye lecture, but we'll tie it in systemically as best we can. And everybody, I think, knows what Scranton is famous for now that we have President Biden in the office. That's where he hails from. He was in Scranton for most of his early life until about third grade, fourth grade, I guess, but comes back to visit, and we just named the street after Joe Biden. But what we're really famous for is the show The Office. Greg, I'm trying to advance that. I think we're playing with the pointer too much. Let's see. There we go. This is what we're really famous for. This is John K or Jim in the show, and that's his bodyguard in the back, Igor, I think. This is at Brown Alumni Weekend. Both alums, and my daughter, I think this is a permanent Facebook picture, which she has probably recently taken down because she's on her third child. But this is John K or Jim, who there's many other films or shows right now. So pretty famous guy. This is the obligatory disclosure list, and this is probably just about all I've done in synopsis the last 25 to 30 years, but we include that. And I don't have anything particularly relevant that's going to impact this lecture at all. My real disclosure, I'm college poor. My kids picked expensive schools, so I'm still paying some of the tuition bills. This is our main office. We have 16 different offices. This is our referral center. We think we have the ratio about right. We have 8 ophthalmologists that virtually are all subspecialists. We have cornea, retina, of course, oculoplastic. Just had a person join us from a 5-year stint at Wills on staff, so we're very fortunate to have Dr. Giacometti with us. But as you can see here, nothing really grows well in northeastern PA. This is the peak or height of the growing season, but that's our ambulatory surgery center on the left and our main building with 36 exam rooms on the right. And I like to think we're a referral center for all of northeastern PA. So that's going to help us this evening share some really interesting cases, I think, with you this evening. So first question is, and we'll get to this at the very end, I hope, time permits. If this is a patient who walked in our practice with 20/20 acuity, as you can see, there's not a whole lot going on in the macular area, but off to the side of the disc, you can see this pretty ugly looking lesion in some respects. It's very interesting because dad came in and he had a history of losing his eye at a very early age, but didn't know why. And this is his daughter, 16 years of age. So to give you a little bit of a hint, it's fortunate for her that she didn't have an early eye exam because they probably would have removed the eye 16 years ago. So see if you can come up with what that particular lesion is in this patient who had 20/20 acuity. Okay, let's see if we can get this to fly here. Greg, can you advance for me, or Joe? Okay, there we go.
Joe, just so you know, we cannot, because you're going from your computer. Just when that happens,
Gotcha.
just click on your screen and then use your arrow buttons.
Okay, should work. I share this case with you. This is something I saw maybe 35 years ago, so very early in practice. Those of you who know Bernie Blostein, Bernie has a lecture on headaches, or at least he used to. I think he's semi-retired now, but he loved this slide that I sent to him. The question I have for you, is this life-threatening? This patient came in to see me with a complaint of a headache. He was holding the ladder for his buddy, and you know those big roofing guns that they use to frame houses. He was holding the ladder for his buddy, and he came down. His buddy let one loose with the nailing gun. They thought it bounced off his head. He had a little bit of blood on his head, but his complaint was he had some blurred vision. So we did a field on him. Sure enough, he had a significant defect to the point where I was concerned. So I sent him over to the emergency room for a scan. And this is a simple scout film. And as soon as the radiologist saw this, he ran out to the waiting room and said, "You better sit down because you've got something really big in your head." So to make a long story short, they just removed that without too much event. The guy was completely traumatized, of course. And to this day, he still has a residual field defect, but this did not kill him, fortunately. So thought that would be interesting. That is not a any type of Photoshop configuration. I think I'm going to delete this pointer, Greg. I'm just not doing something right. There we go.
Yeah, that's fine. I was just going to say, Joe, you ran the visual field and I guess you nailed it, but that'd be a bad pun. So.
There you go. That's right. Yeah, thanks. So, you know, the lecture tonight is life-threatening disease, and this is really not too profound, but again, we're going to define it as a condition where potentially leads to death. It's usually chronic. It's an incurable disease in most cases, but you can see a long list of things that we're going to highlight at the bottom. And these will include cancer, diabetes, and neurologic conditions and heart disease. So this is the top 10 reasons for life-threatening conditions, and it's no surprise to any of you. This is a breakdown from a worldwide survey from 2000 to 2015, so a little bit dated, but I would bet today still at number one is heart disease, without a doubt. And you can see the increase, the number of deaths in 2015. Number two, and somewhat behind, is stroke. The two that come in a close third and fourth would be lung disease, respiratory ailments, and of course, chronic obstructive disease, COPD, which unfortunately we still have a lot of smokers. So we're going to look at the cornea, work our way back, but starting with metabolic disorders, immunologic conditions, and then infectious diseases of the cornea that may signal significant systemic disease. And we'll start with just a little rundown. You know, with metabolic conditions, it can be a deposition or storage of a number of different things. We're used to seeing lipid in the cornea. These patients are often asymptomatic, but how do we tie it into systemic ramifications is what's really important. So, and we know that with any of these conditions, the earlier the diagnosis, the more favorable the outcome for these patients. This is somewhat dated. This goes back to the old Genzyme listing of all the lysosomal storage diseases. And I think I may be off by one or two, but at last count, there were 42 different lysosomal storage diseases. And now I think Genzyme is completely owned by Sanofi, which is a local company that's not too far from where we practice and very well known for their vaccines. Okay, here we go. So a diagnosis is really simply made by a blood draw and the top of the list, but you can certainly include cases that have been diagnosed by simple genetic counseling. We had the two that I'm going to highlight are Fabry's disease and cystinosis as the two recent lysosomal storage diseases that I've seen. So I usually ask the question when we have a live audience is, how many of you have seen in your career a lysosomal storage disease that you personally have made a diagnosis for? And usually one or two hands go up in a room of a couple hundred participants. So you usually look at the average age of the practitioner, number of years of practice years, which is probably well over 300 or 400 and way beyond, sometimes even up above 1,000, and rarely do a hand go up. And I've had two the last 15 years. So the question I have for all of you, what have you missed and what did I miss the first 20 years of practice? Because just having two in 15 years is probably not an anomaly or an aberration. I'm sure each and every one of you have probably seen one of these, but have either passed it off as being something benign or just really didn't know that there was a connection with a lysosomal storage disease. So you can see the New York State group, the health department does screen for 6 different lysosomal storage diseases. And that's thanks to Jim Kelly. If you're a Buffalo Bills fan, you know, quarterback Jim Kelly, son had a lysosomal storage disease and was a big advocate for early diagnosis and screening for these patients. So let's take a look at the corneal diseases that we might encounter. And as I said, the 2 that we're going to really highlight here would be corneal crystals, cystinosis, and then the verticillate that you see, kind of the brownish pigment type of verticillate that you can see with Fabry's disease. So I think the big take home from this slide is that these folks are often on a diagnostic odyssey. You can see the very discouraging numbers at the bottom where 1 in 7 remain undiagnosed for 6+ years. 36 remain undiagnosed for well beyond a year, but they're going from one physician to another and certainly considered part of the NORD group or the rare disorders. So the 2 cases we've had of Fabry's disease recently in our practice, from those 2 patients, it's a sex-linked disease. So they were male-affected patients, but from those 2 cases, we've identified 16 other family members. One of my patients, his sister had 2 males that were afflicted, and they were diagnosed at a very early age and now getting systemic treatment. So it's simply a matter, if you don't have to remember this, but it's alpha-galactositis A. My patient came in, he had just had a stroke, and I looked at his cornea and said, gee, when are you due for blood work? He says, I'm actually having it tomorrow. So I just simply wrote out a script for alpha-galactositis A. And I guess his primary care physician got the blood work back before I did because there was a marked deficiency. And he said, well, you had a stroke because you have Fabry's disease. He wanted to know who ordered that test. And they said, my optometrist did. So you can be the hero in many of these cases. So just pay particular attention to what you're seeing in the slit lamp. Sadly, I looked at this guy probably a year earlier and he had just a little bit of pigmentation in his cornea and he was on indomethacin, and I kind of attribute to that. So I blew it by a whole year, but we got him back on track and he really lived a pretty long time. He just passed away about 6 months ago. This was my first case many, many years ago of Fabry's disease. You can see the treatment or the infusion therapy that they get usually every 2 to 4 weeks, depending on which company you're working with. A lot of different systems affected. You can see the dermatologic signs where you get angiokeratomas right along the bathing suit line. They certainly have heart issues, lungs, kidneys, liver. These patients have multiple systemic ailments. And here you can see a classic verticillate from Fabry's disease. I swear to you that the patient I had just a little spot in the center that really could have been confused for a Hudson-Stolly line, but it's more curvilinear. Tends to be where centripetal motion across the cornea occurs, and that's below the midline. So you have to look closely, but if you bring up the magnification a little bit, and as long as the patient's not on an amiodarone, which can look very similar to this, that would be a differential with drug toxicity in the cornea. You just don't want to miss one of these. And carriers can have some signs as well, even though they're not afflicted, because typically it's a sex-linked transmission. They get lots of petechial hemorrhages in the eye and elsewhere. You can see their fingers, toes. You can see, slide up on the right. If you see something like that, I would be a little bit concerned about polycythemia vera, which should not be missed with simple blood work on these patients as well. They get these little petechia on their tongue as well. So you can see that there are obviously some systemic ramifications here, and you just might extend the life of those patients if you make an early diagnosis. Here's a patient who has tyrosinemia. This is like a Mickey Mantle baseball card. There's only, I think our whole group collectively with 36 clinicians has only seen 1 case of this. This is Richter-Harnhut syndrome or tyrosinemia. And this is type 1 or type 2. You're not going to see type 1 because those folks die in the hospital. They're very young, significant metabolic ailment, but type 2, they tend to do pretty well with appropriate systemic treatment. They can have these incrustations on their digits, fingers or toes, and usually the dermatologist makes the diagnosis, but you might be the first one to see them. Let's shift away.
Joe, before you
right.
go any further, we have a question. And I'm guessing it's the patient that you just talked about that you diagnosed and then recently passed away, but it says, how old was the patient? And when was it diagnosed?
Initially diagnosed probably about 15 years ago. He was in his mid to late 40s and he passed away. I think he was just about 60, but lots of renal issues. So with a late diagnosis, he had significant, renal tubule issues. My cousin is a renal specialist in town and he took care of him. And he ended up dying from kidney failure, as many of these do. And it can be heart issues, but a lot of them pass away from kidney failure.
Good. You asked that was my next question. What have you seen as the, yeah. And then, so help me out, because I'm getting nervous now. I've been practicing 25 years. I do a lot
You
of,
didn't have any?
I don't, well.
Yeah, listen, I don't mean to be critical because maybe you haven't seen any, but what are the chances when you poll an audience of 100 clinicians with practice years of 10 to 15 years or longer as average, that somebody in that audience hasn't missed something? And like I said, I had 2 in the last 15 years, but what did I miss the first 25 years of practice? I don't know.
Yeah, and that's kind of where I'm sitting. So just remind me where the question I was going with it is, what's the blood work? Is it is it a simple blood test?
You look for the alpha galactosidase A deficiency, and it's pretty straightforward. You don't have to memorize that. You just look up Fabry's disease. It'll be there. Yeah.
Okay.
So we're going to move from metabolic corneal conditions and kind of briefly just touch upon some examples of inflammatory conditions that might signal systemic disease. And here you see just a few examples, including lymphoma or other paraneoplastic diseases, and including renal failure. And here's the example. You've got a patient who has classic band keratopathy, where you have deposition of calcium. Surprisingly, this is not a calcium metabolic problem. It's more of a phosphorus problem, but you get a paradoxical input or influx of calcium in the cornea. So you can see these with traumatized eyes all the time, but this is a patient that actually had a parathyroid dysfunction. So it wouldn't be a bad idea, if all else is good in their systemic history, to get an intact PTH or serum calcium levels just to see where that lies. So that's one example. Now, from inflammatory conditions, one example, infectious diseases, kind of the classic one is flectenulosis or interstitial keratitis, and a number of reasons for both of those conditions. Fleck-10s are not pathognomonic for any one particular disease. It's just a simple response to microbial antigen. And here you see a partial list at the bottom. The big thing for us in Northeastern PA, and I'm sure, Greg, you're in the same territory, is the number of new cases of Lyme disease that we're seeing. It is the state disease of Pennsylvania, without a doubt. Tuberculosis is back as well. We keep hearing that, but it truly is. And I gotta tell you, Pike County is one of the counties that we cover. It's one of 5 counties. And just last year, they had a case of just a big upshoot of Lyme disease, because it has the highest per capita of new cases in the whole country, but they had a case of leprosy of all things. So it is considered Hooterville from where we live, but we cover it, and there was a case of leprosy. So you never know what's going to walk into the office. So keep a sharp eye out for that. On your left is a classic staph reaction, Fleck-10 on the cornea, kind of a triangular web shape on the cornea as well as the conjunctiva, and much more significant Fleck-10 response on the right. And this is a patient that was positive for TB. So as I said, TB is back. For those of you who are not familiar with metagenomic deep sequencing, it is absolutely the hottest topic right now in infectious diseases. So it really gives you an unbiased approach. And what you're doing is integrating all the genomes into a simple clinical sample, unlike PCR testing, where you've got to tell them what you're looking for, okay? If you've got a patient and you think it's viral, you got to tell them that in the PCR testing, I'm looking for a virus, okay? Could be something else. It could be bacterial, could be fungal. But if you don't specify, I'm looking for a specific pathogen, they can confirm it, but they may not find it because you don't get that broad genome sampling like you get in metagenomic deep sequencing. And unfortunately, there are only a few labs in the country that are doing this. But as time moves on, I think we're going to see it more and more on the ophthalmic side of the equation. It's very, very easy to make that diagnosis.
Hey, Joe, can you go back, 2 slides
Sure.
now? It was the cornea. We all like to, sit back and talk about.
This one?
Yep, that one there. We like to say flectannual and all this fun stuff. And you can see the redness in the injection, but the little white, buildup. If you would biopsy those, would those be white blood cells? And
yeah, there are inclusions, and they could be, range anything from eosinophils to, response to the microbial antigen, and just really heaped up white blood cells. As long as the patient's breathing and thriving, you're going to have some type of immune response. And even though this is an infection-driven picture, there's certainly a lot of inflammation there in this particular patient.
That's what I really
they
want
would
the audience
respond
to
pretty well.
And that's really what I
Respond pretty
want the audience to really understand here is that, we sit back and we say they're flectennials, but if you guys study those, look real closely, it's just basically an accumulation of, as Dr. Shovlin said here, white blood cells, most likely eosinophils building up. So just white blood cell accumulation. That's it. That's all I want to point out.
So we're going to move to our second case of lysosomal storage disease, corneal crystals. In particular, this case is cystinosis. And this is, as you can see, is an autosomal recessive disorder where you have a storage of cysteine in the cornea because you don't get the conversion from cysteine with an E to cysteine with an I. And it's a simple blood test. You just ask for serum cysteine levels with an I, and you'll get an elevated cysteine level. So our last case, and I'll show you a picture of her, she unfortunately also has passed away in the last 6 months, but I followed her for probably close to 5 to 10 years. And everybody who would ever see her would love to take a look at her cornea because it's just really staggering to look at these little non-reflective or refractile crystals in the cornea. But the big differential is to really rule out multiple myeloma, in particular, any lymphoproliferative disorder, because it's not pathognomonic for cystinosis. Turns out she did have cystinosis, adult cystinosis, so she had some renal issues. Kids or young adults have more morbid disease or potentially fatal disease with cystinosis, but adult cystinosis patients do pretty well. But she also had MUGUS. She had a unknown significant gammopathy, monoclonal gammopathy, and she was followed for years. And I think eventually that's what killed her, is her gammopathy. So, of course, she was getting older too, so that's probably an issue. Here you see one patient who was diagnosed with multiple myeloma, just a couple little crystals in the cornea. This is our patient on the right with a very significant scattered. It looks like it would change with a blink, but that's not in a tear film, that's in the corneal epithelium. So as it turned out, I think maybe her crystals were more related to her cystinosis. However, she also had a positive Bence-Jones test. So the big differential here, as we said, is multiple myeloma. You can see some diagnostic criteria here, and the treatment for these patients is really getting much better. We'll show you a medication in a moment for multiple myeloma, Blenrep in particular, where you get corneal toxicity. You get this kind of microcystic epithelial change. It's kind of yellow in appearance, but these folks have to be monitored very closely because they're going to lose vision if it continues. And they usually get the deposition after on that medication for at least 2 sessions. So these folks with multiple myeloma are easily bruised. We had a patient today, I think one of our students is on this evening, where my concern was she's had multiple bruising. So she was seeing her hematologist because she had breast cancer, and her oncologist is also a hematologist. We're going to ask for some blood work because of her multiple bruises. She had a big bruise underneath her eye, and she said she keeps getting them, even though she's on like just an 81 milligram aspirin, which can be significant, but we're hoping that she doesn't have some type of blood dyscrasia. These are both examples of multiple myeloma, our patient on the left, and you can see the coagulated or the kind of buildup that they can get sometimes. This is courtesy of Oliver Shine at Hopkins on the right, and you can see they coalesce or kind of morph together, if you will, and that would be something I'd be quite concerned about to make sure you get the appropriate blood work and testing. This is probably just a simple intraepithelial neoplasm, but this patient was worked up for multiple myeloma as well. And I believe, if I'm not mistaken, it was negative for that. But that would be something you'd want to do as a differential as well. Kaiser-Fleischer rings, of course, could suggest Wilson's disease. The ones that I have seen have all been sent in because I've got a neighbor who's a liver specialist, so he wants us to check their cornea. But the diagnosis was already made. I don't recall ever sending somebody out for a blood test to rule out Wilson's disease just based on what I saw in the cornea. I mean, you might see somebody who's got deposition. We'll show you what that looks like in a moment, but it is absolutely positively not pathognomonic for Wilson's disease. And you can see what pops up again, and that's multiple myeloma. So you need to be able to make those differentials as well. So let's take a look at what that might look like in clinical practice. These can be yellow, they can be green, they can be brown, but they're in the deeper layers, unlike what you'd see in keratoconus, which would be the basal layer of the epithelium. These are quite deep into the stroma, even down to Descemet's membrane. So You don't want to miss these if it's the first time that patients ever heard the term Wilson's disease. Lots of neurologic signs with these patients because of the comorbidities, but your diagnosis, if you're going to do blood work, would be a reduced ceruloplasm, and then looking for an increased urinary excretion of copper as well. And there you see the treatment down below for these patients. We're going to shift away a little bit from the cornea to things around the eye and on the conjunctiva. I think probably one of the most interesting cases I've ever seen in clinical practice in almost 40 years is a patient who came in with her third bout of herpes zoster in 18 months. So the question I have for the audience, is that normal? Is that something that you typically would see, the third bout? And Greg, you just had a lecture on herpetic disease, and I've had the good fortune of doing that with you a number of years at the Academy meeting. The question I have for everybody, is that normal? Somebody having zoster, shingles, 3 separate times, different locations. I happened to see her on the third time because it was around the eye, and the other 2 times different locations. What are you worried about here? There's got to be something with cell-mediated immunity, a reduction, some concerns there. The first thing we did was check her. She was 29 years old, so we checked her for HIV. Unfortunately, she was HIV negative. But what would be the next thing you'd really worry about? Well, what might cross your mind if she's HIV negative, and CMV as well? She was negative on both of those. But turns out we scanned her thymus gland. You know, you think about what produces T cells. This is a T cell mediated immunity reduction. The thymus stores T cells, so there's direct link there, and sure enough, she had a thymoma. So much like our patients with myasthenia gravis that you want to check their thymus gland because of T cell input, she had a thymoma. And unfortunately, she refused to go down to the University of Pennsylvania because Dr. Kaiser was going to do a bronchoscope, but she didn't want to leave the area. So to get to the thymus gland, you have to crack the chest, and they cracked her chest. Unfortunately, the tumor was removed and she had a benign, it was a thymoma that was benign. So keep in mind that these folks are at higher risk for stroke, regardless of their age, and maybe the link or possible trigger. I've seen different reports on the link with shingles and giant cell. And just keep in mind that I don't think there's ever been a reported case under 50 of GCA or giant cell arteritis or temporal arteritis. Okay, so this is what you'd expect to see in the cornea. You see these dendritiform lesions. These are not herpes simplex. Unfortunately, we saw somebody today, and one of our clinicians said, well, you have herpes zoster or shingles, and it was a true dendrite. These are not ulcerative. These do not stain well. These are plaque-like and raised above the epithelium, unlike herpes simplex would be the only true ulcerative lesion. So this is what you'd expect. And these can be PCR positive for quite some time. Unlike this, these are the ulcerative dendrites that you see in herpes simplex, and this is bilateral. So what do you think about when you have bilateral simplex? Well, in the younger group, you need to worry about atopic profiles or atopy. But if you've got an adult patient, or even a younger patient for that matter, who has bilateral simplex, there's something not quite right here. In the last 2 cases I've seen in patients over the age of 50 with bilateral herpes simplex, both of them had occult cancer. One patient was actually being worked up at the time for cancer. So you need to think about something a little bit more sinister when there's bilateral lesions like this, because the patient may actually indeed have an occult cancer. And here again, diagnostic confusion. You see some pictures at the bottom, but this is not by all means not a complete list of what you see. And these things fortuitously branch out into a dendrite pattern. Again, the only one that's a true ulcer is down the bottom. Number 2 is our friend with herpes simplex, quite a big lesion. So keep in mind, in contact lens wearers, these are all patients with acanthamoeba. They have dendritiform lesions. They tend not to stain very well, as you can see in the bottom left, but on white light above and with some fluorescein at the bottom and a cobalt filter, these sometimes can be confused by even good clinicians, maybe not so good, but some decent clinicians who think these are herpes simplex and are not. This is when I am on call, and I'm on call this week. I hope I don't get buzzed in here in the middle of this lecture. I told them to hold it for 2 hours, but this is a patient that had a lesion. This is courtesy of Blair Lonsberry. And anytime I hear, I've got a spider bite, well, I'm going to think shingles or MRSA. And this particular patient actually had MRSA. But anytime somebody tells you they got a spider bite, it could be, but you need to think about the pain involved. I just had one about 10 days ago and just kind of mortified, but you know, it's the type of thing where the second or third person that sees them makes the diagnosis. She came in on a Saturday morning and she had pretty intense pain and she's not prone to headaches. So it's always the first headache, the worst headache. And I said, you know what, Saturday, I think you need to go down to the ER so they can scan you. So they went down, they scanned her, everything was good. I called her, talked to her. She calls about a week later and said, you know, I saw my primary care physician and I have shingles. So, you know, her first sign was the pain. But you know, you need to think about what could possibly cause that type of pain. And it turned out for her, it was shingles. So we're going to move to the conjunctiva.
Hey, Joe. Hey, Joe, I want to use the
Great.
chat box here. We don't really have the, a formal survey here, but you brought up the old infamous spider bite. And I'm in Pennsylvania, you're in Pennsylvania, and that's kind of a little standing joke at my office. It's the infamous the infamous spider bite. And it's always something like you just said there, MRSA, simplex, you know, something, you know, basal cell on the lower lid. You know, how long has that spider bite been there? Oh, yeah, like 9 months. So I'm just kind of curious. Is it something regional Joe and I have? You guys can use the chat box. Have you guys, have you guys had this infamous spider bite? If you can just type it in there and Joe, keep going.
I've been on both sides of this. I've been the hero, I've been the villain, like this lady who came in with just head pain and she turned out to have the shingles. If I got to see her a couple of days later, I would have seen the vesicles. But I had one a couple of years ago where, yeah, it looked like she had a suspicious lesion just on her lid. And I thought it might be something that we'd want to biopsy. Her son is a really great neurologist. A patient of mine, he called me back 3 days later and said, guess what? She's got shingles. I said, oh no. You know, so it's the type of thing where I've been burned. I had one where the patient came in and the primary care physician said, you have a spider bite, put her on an antibiotic. She wasn't getting better. He sent her to a dermatologist. He said, yeah, this is a spider bite. Let's put you on prednisone. So she wasn't getting better. She saw me. By the time I saw her a week after, she had them in her nose. She had them in her mouth. I said, you have shingles. He said, what? I said, yeah, this is shingles, sure enough. And she didn't want to believe me because she had seen her physician and dermatologist, but she definitely had shingles. So sometimes you're the hero, sometimes you're the villain. So yeah, I think, I don't know about the geographic differences, but yeah, spider bite, I think, yeah, it could be. But I certainly want to rule out shingles, or at least tell the patient, look, if you look different or feel different, you need to let us know. And as long as they have good renal function, I have no problem putting these patients on Valtrex. I mean, I just, you know, you're going to be the hero if you say, look, this could be shingles. It may not be, but it's certainly not going to hurt you to use Valtrex for several days.
So I'm looking at the chat box, Joe, just so you know, it might be something in Pennsylvania that the patients use, getting a lot of no's and a few people talking about recluse spiders. And, you know, a couple people have said yes about the old infamous. Yeah, it's funny, but like I said, it's a standing, like every time, oh, doctor called, well, there's an emergency coming in. What is it? Oh, because it's, you know, it's someone answering the phone and they don't, they get the patients in and they know something, and it's the old spider bite. And we just all kind of roll our eyes in the back going, yeah, this will not be a spider bite, but go ahead.
On rare occasion, it could be. Yeah.
It could be. Yep, I agree.
So here's a patient that we saw many, many years ago, and unfortunately no longer with us because this is the third leading cancer of the eyelid area, and this is sebaceous gland carcinoma. So unfortunately, patient was sent in with a cornea that looks like this on the right. You see the lid involvement on the left, right eye. And you can see the leukoplakia, you can see the petechial hemorrhages, and this was diagnosed wrongly as unilateral SLK. This is not Theodore's SLK, sadly. And the patient really had a very, very significant disease. And this spreads very significantly like melanomas through the lymphatic system and beyond. So the patients usually do not do well when it's that morbid. So the mortality rate is very high for these patients. Here you can see again another suspicious lesion. You know, we weren't too concerned initially about this, but it was biopsied and it was cancer. So where our oculoplastics guy is just phenomenal. We'll share a couple cases that he's seen recently, which are really good. I saw him just do a 90-some-year-old, like 92-year-old patient who he did the biopsy. It was sebaceous gland carcinoma. We send it to a local Mohs surgeon, had 4 passes. Patient came back with no upper lid. He took skin from her forehead area, rebuilt her lid. 6 months later, you can hardly tell she's had anything done. So that's a real gift to be that talented. So here we see, again, much more suspicious lesions, and these all turned out to be a form of cancer. So when in doubt, it's always best to get somebody who can biopsy these for you. And some of them can be pretty straightforward. Some of them can be very significant, like the one down on the bottom left. This patient had intraocular involvement as well. So you need to really pay close attention. I've included this because this is a patient we just saw probably about a week ago. It's probably not in your handout even, but take a look at the lid. You know, you've seen kind of some of these on occasion in non-contact lens wearers, and this is pretty funky. You can see these kind of really weird looking gelatinous lesions that kind of sparkle back at you almost. But when we dilated the patient, it came in because of reduced acuity. You see this glass wool vitreous, and this is pathognomonic, pretty much pathognomonic, this glass wool vitreous for amyloidosis. So patient does have systemic associated disease. So it might really help these patients from a metabolic standpoint to make an early diagnosis. So you can, you know, be on the lookout for that type of glass wool appearance. And then not that that's pathognomonic on her lid, but it's pretty suggestive of something else is not quite right here. But yeah, the glass wool is pretty much pathognomonic for amyloidosis. Here's a patient that our oculoplastic, I just mentioned I'd share a case with you. And this is kind of sad because, as you can tell, this is a pretty young individual. And she was sent in when she was 17, I believe. This is about a year ago. And she has what the referring doc says, I think she's got a preseptal cellulitis. Well, she probably does to, you know, your liking, and there's certainly appearance that it could be a chalazion. But what we're going to show you here in a moment is just much more morbid. If you take a look at her EOMs, take a look at the movement on the top slide. You can see she has extreme difficulty elevating that left eye. And the reason she has a very difficult time elevating that left eye, she's got this humongous mass. You can see on axial and coronal views, you can see that huge mass up here in the cornea, and especially up here in the left side, you can see how large that is. So that was removed, and you can see what was removed there. So pathology came back not so great. This is a rhabdoid tumor, but take a look at the growth just in 3 weeks. This is 3 weeks difference. Here's 3 weeks after removal. This is before surgery on the right. This is not, she really looked pretty good after this initial surgery. This is 3 weeks after. So we scanned her again, and unfortunately 3 weeks later, look at what this poor kid has. So she's been radiated a number of times. We don't know what her life expectancy is, but sometimes things as simple as a benign, what looks like a chalazion preseptal cellulitis is much more involved. So check the pupils, check the muscles, get a scan when in doubt. You know, we have coverage at the local hospital, so it was very easy for us to get imaging on her. But just look at that morbidity just in a 3-week period of time. It's kind of scary to see how quickly that grows. I'm going to move back in the eye a little bit, and I think our next discussion is going to center around iris flocculi and the potential for familial aortic dissection. I had a patient who was in just maybe about a year ago, and I said, you know, you've got these really interesting looking flocculi, which you can see all the time on the left there and down at the bottom. And I said, you know, one thing we can do, because there can be a familiar history of aortic dissection. She said, my father is one of the few people that his doctor said survived from aortic dissection when he was 93 years old. So we got her scanned, got a CTA, and sure enough, she had potential for aortic dissection in the thoracic area, abdominal, but most importantly, the thoracic area. And here you can see on scans, one on the top there would be more a thoracic dissection, and then the one at the bottom, you can see both thoracic and abdominal areas. So when in doubt, get a CTA or just refer it out to the primary care physician. I bring your attention to other things that can cause aortic problems and dissection in particular, and that's even the use of oral fluoroquinolones. You can get, you know, tendon tears, the whole bit. So I had one person one time where I did an interview with one of the throwaway journals talking about the benefits and the beauty of using fluoroquinolones. And all he did was go on a rampage about how dangerous these drugs are. And we're talking about systemic treatment. You know, again, there's no question you need to be a wise clinician, especially when you prescribe things from a systemic standpoint. So let's take a little shift and move to the back of the eye. And we're going to spend the rest of our time, probably about an hour or more, on just what we see in the back of the eye.
Hey, Joe, I hope you don't mind me stepping on you, but you know, I do that lecture complications, and you certainly have sent me plenty to that. So thank you for helping me out with my lectures. But I do want to clarify to the audience out there that, you know, I used to have my fluoroquinolones as my fourth spot. You know, we have penicillins, we have our azithromycin, your macrolides, you have cephalosporins, and then before sulfa, I had my fluoroquinolones as my orals. Sulfa has moved up in the fluoroquinolones, as you just said, from all these systemic. But my whole point of going through all this rambling on is to clarify that topical fluoroquinolones are safe, right? It's when you go
Absolutely.
orally, just be careful. So I just
Yep.
wanted to clarify that to the audience.
Absolutely. Yeah, totally agree. So I think, a wise person once said, there's nothing more expensive than the wrong diagnosis. And especially when it comes to potential harm to the patient, not to even touch upon the medical legal implications, because unfortunately I probably do try to avoid it like the plague, but if I do two or three cases a year for medical legal discussions, and some very interesting, cases that you come across, and some really good clinicians getting into trouble through no fault of their own. And I tend to favor the defense. I've only one time taken a case for the plaintiff. But, again, this is a potential harm in missing neuro-ophthalmological conditions. And I think Joe could probably do a 5-hour lecture on this, but I'm going to hit upon some of the clinical things that we see. There's a lot of information on these slides, and I would refer you to the handout because in the interest of time, I'm not going to talk about every single bullet point. But what I'm going to do is point out from a clinical perspective what might be beneficial for you as a clinician to really look at. And a big part of this is, are flashing lights benign? And they're not. I mean, we know the ravages from a potential ocular standpoint, and our job is to make sure these patients don't come in with a retinal tear or, God forbid, a detachment. But we need to think way beyond that. And some of these cases I'm going to share with you will highlight the potential for both neurologic and vascular conditions that will give you flashes of light. The eye can only respond with so many symptoms. So as part of your adequate history, you need to really talk about location. Are they central, peripheral? Temporal would be more potential vitreotraction. Is it one eye or both eyes simultaneously? Are they prolonged? Is it constant? We had, and again, I would like some help on this. If anybody wants to share anything with me, please step in, because we've had a patient who I've seen the last 2 weeks who swears she has constant flashes and they never stop. So we scanned her. We were worried that she might have a stroke. We thought she might have a seizure disorder. Everything is completely clean on her, but she has this flickering that's constant from the moment she wakes up till she goes to bed, just in one eye. Now she's had a buckle in that eye, but it just happened out of nowhere, and her buckle was done probably about 5-6 years ago or more. So Joe, if you've got any thoughts on that, I'd love to hear your thoughts. Again, she was checked for seizures. She had a EEG. She's had everything. Her carotids were checked. We looked at her from a vascular standpoint. She had an MRI. She had a CT from her primary care. We even went and got an MRI on her and an MRA just to make sure she didn't have an aneurysm, because this one case coming up is going to highlight that MRIs are not sufficient in some of these patients, and we'll tell you why.
Well, Joe, with neuro-ophthalmic disease, people have to accept sometimes you don't find an answer, but you do your fiduciary duty, rule out everything that you can think of. And, once you get through the things that can blind and kill them, sometimes you're left with no answer.
I think that's a beautiful statement. And I think it's so true. We have one of our docs spent 3 years with Bob Surgot at Wills. So he's kind of like our go-to neuro guy. When he's not sure, we'll send it out. But we've kept track of the last 6 cases that we've sent down to Wills or over to Danville to the neuro-ophthalmology. If we didn't have an answer for them, they didn't have an answer for them either. And we have to chuckle because often they'll come back with a diagnosis of small vessel disease. So, that's kind of a basket collection. So you're absolutely positively right. We're human. Sometimes we don't have an answer for things, and some things just you can't explain. I mean, it's beyond what we can really look for.
But
we do our job to rule out the bad things, and sometimes we just don't have an answer.
But I think many times optometrists are like philosophers searching for truth. And if they keep going and going and going and testing up, they will come up with an answer. And we have to accept that, that doesn't happen.
Yep.
Interesting, a lot of these things that I see in my practice will come from retina. And
Yep.
the diagnosis they put on there is not retina. Well, not retina is not a diagnosis. And most every time these neuro cases become actually retina.
Yeah. And they're punting because they don't know what else to call it. Yeah.
Mhm.
And that's the nice thing about optometry is we don't give up. I mean, we are dogged. We just do not give up. So is there any color appearance to it, which would suggest maybe some type of seizure disorder? And in any other, of course, most importantly, do they have any other associated eye or medical conditions? So including medications, what medications are they taking right now? So this is a
We had a
very
comment,
elaborate,
Joe.
detailed
Joe,
pathway.
we had a comment in the chat box, and it says, did this patient recently have cataract surgery?
Patient had cataract surgery probably 10 years ago. No symptoms after that. So no disc photopsia. We've looked at her from head to toe and just cannot come up with it. And I'm not sure what would give her constant flashes. She could, from the moment, and they're synchronized. They're not sporadic. It's not like with eye movement. It's synchronized. She's got bing, 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 bing.
The only thing I can say, Joe, is that when I worked and did a lot of retina, I worked with a retinal specialist and did a lot of buckles. And it's kind of funny that you said it was correlated with that. And I'm not sure if there's something that shifts, but there was a handful of patients that would get these constant flashes of light in that retinal attachment eye. And it seemed to correlate with our heartbeat. So I'm not sure if it correlates with the heartbeat, and there's something where, there's a blood vessel shift in that buckle, and it just kind of gets against that optic nerve head and kind of gets that heartbeat type of thing. That's anything I could ever think of. But I've probably had 4 patients, but I'd put my finger like right on their wrist and feel their heartbeat, and they could correlate it. But I'm not sure if that's your patient.
We're always troubled by pulsatile vision or whether if it's synchronized with their heartbeat. So yeah, we usually scan them. And this person did get an MRI and an MRA, so we're pretty comfortable with that assessment. But yeah, I mean, that's what I'm leaning toward, is there's something where there's the buckle stimulating this, but it's so synchronized. That's what's troubling. I don't know. This shows you the pathway, and congratulations to anybody who can memorize this. If you got a photographic memory, good luck in kind of reciting this, but there's a lot of potential along the pathway here to give you flashing lights. So this is by no means a complete list, but these are cases we're going to talk about. And you can see, starting at the top, our job is to rule out any type of pressure phosphene or entoptic phenomenon that might be related to vitreous traction, just to make sure that patient doesn't have a retinal tear. And we know we'll bring them back at 4 weeks, because if they're normal today, you bring them back at 4 to 6 weeks, because there's about a 2 to 5% chance they're going to have a retinal tear. If they have a retinal hemorrhage or a vitreous hemorrhage, then I think the odds go up. I mean, a vitreous hemorrhage is about an 80% chance they have a retinal tear. And if you don't see one, you better make sure somebody else is taking a look at them, because you don't want to miss these things and have them come back with a detachment. Any type of neovascularization, patients that have macular degeneration can give you a central photopsia. You can get some unusual things from Graves' disease, of course, and the person asking about a intraocular lens, certainly IOL dysphotopsia, either positive or negative dysphotopsia, is a possibility. We need to worry about melanoma-associated or cancer-associated retinopathies. We just had our patient in today who had a melanoma, and her only complaint when I saw her 5 years ago, I think it's more than that, probably 6 or 7 years ago, the only complaint she had is she came in because she had flashing lights. And you just kind of get sick to your stomach when you dilate them and you see these ugly looking suspicious lesions. And we say, we're going to send you down to Wills and see Carol Shields, because she's the person who can best handle this. Migraines are a diagnosis by exclusion, but certainly vascular etiologies, and you need to worry about those over 50 with the potential for giant cell. And again, here's a partial list of medications that can give you flashing lights as well. So aneurysm, the AV malformations, we'll show you an example of a case where the patient had these peculiar looking retinal lesions in Weber-Landau syndrome that had an AV malformation. So you might save them a tragedy down the road if you can identify these ahead of time, so they can be monitored very, very closely, including seizure disorders, which is what we thought about for our person who came in with these constant flashes for the last couple of weeks. If you look at causes of unilateral traction, can be mechanical, certainly can be inflammatory or vascular. And PVDs, again, 15% of your patients that walk in with symptomatology are going to have a retinal tear. And as we mentioned, you worry about that 5% that may have a tear on subsequent visits. So we have to laugh because our students on here heard me talk about this, but we had a patient who I saw in November who had flashes and floaters, and she had a hemorrhage at 1 o'clock, but she had a really small breakup at 12. So I sent her to the retina person. Our guy was having his hip done. So I sent her south to Geisinger, and this guy is really very good. So he depressed the heck out of her, and I didn't get a letter back. And to make a long story short, I saw her for her routine exam 3 months later. And I said, "Did he fix your tear?" And she said, "No, he didn't see one." I said, "What?" So I dilated again. I put the 3 mirror on and had our student look. He said, "Oh, was that a tear?" I said, "Yeah, that's a tear. And it's the one we saw in November." So I sent her back a third time. He's depressing the heck out of her, saying, "Geez, this guy's good. I know he saw something, but I don't see anything." And she said, "Well, he didn't really see anything either till he put the 3 mirror on." So he puts the 3 mirror on. He says, "Oh, you have a tear." So I finally get a letter back from this guy, and it says new tear. No, it's not new. That was there in November. New tear, but in brackets, he had Dr. Shovlin 3 mirror. So that was his code word for, okay, I think this was here in November, and I probably missed it with scleral depression. So get good at a 3 mirror. I mean, I'm not great with depression, but I can look with a 3 mirror. And I've seen things that really are very tiny, and they may be, insignificant to some, but these things can really open up and cause a detachment down the road. So get good at the 3 mirror if you're not a good depressor. And even if you are a good depressor, don't be afraid to put the 3 mirror on occasion. So let's look at some vascular etiologies. Again, it could be a simple retinal spasm. As I said, migraines are a diagnosis of exclusion. And we're going to make a differential later on between TIAs or transient ischemic attacks, which can be monocular or bilateral, and amaurosis. Amaurosis is an ocular etiology. TIAs or cerebral or brain etiology. And people make that big mistake. Now, you could argue amaurosis is a form of transient ischemic attack, but they're different etiologies. One being ocular, the other being cerebral in configuration. So, the classic migraine, patients got a visual aura for several minutes, up to 20, 30 minutes or beyond, up to an hour perhaps. They can have, an atypical migraine where it lasts longer than that, but you really want to make sure that these are classic migraines. And the big thing for me, and I'm going to do it in the summary in case I, don't explain it well here, red flags for me, and somebody comes in with visual auras, is do you have a headache before the visual disturbance? If you have a headache before, it's common not to have it at all. It could be acephalic or comes after. But if somebody has a headache before the visual disturbance, that's a definite red flag. Those patients should be imaged because they've probably got something else going on here rather than a classic migraine. Or if somebody comes in at 60 and they don't have a history of migraines prior to 40 or 50, that's also a red flag. Now, you can't scan everybody who comes in the door because they probably have a simple migraine. But, you have to really weigh the evidence and just be very careful that you don't miss something that's really significant. Bilateral causes of flashes, again, some overlap here. Certainly migraines, 30% can be bilateral. Drug-induced side effects, digitalis and Seroquel. This is, again, a partial list. We talked about bilateral retinopathies with RP patients. Any type of tapeto-retinal degeneration certainly can give that. And again, most importantly, an autoimmune paraneoplastic disease, and including the cancer, CAR-associated or melanoma-associated retinopathies. Charles Bonnet, of course, we see a couple of these every year, and they're fascinating to talk to patients because family members are ready to commit them to the nut house, but these are seeing children's faces on the wall or animals on the wall. And a lot of folks with AMD are going to have these types of visual phenomenon, but you also have to worry about some problems in the cerebral cortex as well. As we know, when we see patients with PVDs, 96% typically are quick. They get a lightning flash at white in color, temporal location. And again, some, at least a fair number, will have some type of tendency to have associated floaters. So we tell folks if you have flashes, specks, cobwebs, anything that's unusual or different, you come back in to see us, okay? And certainly a preferential for flashes in the dark or when there's quick head movement. So again, that'll help you make the differential. This is what you hope you don't miss along the way. There's a large giant tear with associated detachment on the left, and just simply with the optos, nice retinal detachment of the patient on the right. So there's our first poll question, guys. If you want to launch that, we'll do the first question of the evening after a whole hour. So pipeline embolization, we're going to talk in a moment about aneurysms. Pipeline embolization is a clotting technique, and I think I just gave the answer away, but really is a recent strategy used to treat what? Certainly not epiretinal membranes. I think we're going to get 100% here because I think I just gave it away. So I'm going to vote 2, and then we'll bring this up in just a moment.
And just so everyone knows, The handout I launched a while back, it's in the chat box. I'll launch it again. It's basically Dr. Shovlin slides tonight. So, and it was in the 645 email too. All right, looks like we're getting a little bit higher response. Remember, everyone out there, please respond. COPE has been nice enough and the state associations to allow us to do this and make it live and interactive. So please respond to the polling questions that are out there.
So we made it pretty easy for you. It is one of 3 options in treating. Okay.
And there you go. I'm sharing the results
for
for
you,
you,
Doc.
Doc.
Cerebral aneurysm. So absolutely correct.
Just so you know, Dr. Shovlin, there is a 5th answer that I add listening to our polling or to our surveys. People said you should put on there, not sure, and that's why I'm here. So I did add that to your polling.
Good.
So
Thanks, Greg.
Yep.
So, this is probably one of the most interesting cases I've seen. I keep saying that, but this really is really quite interesting. And, you're the hero on these. Sometimes you can be the villain, but this is a patient that had a kind of a twinkle flashing, constant flashing. It was sensed to be bilateral. I was not convinced it was, but her primary care physician sent her in just to make sure he didn't have a retinal tear. She had already had an MRI of her brain because she had loss of smell. And this was pre-COVID. So this is before COVID where we'd worry about it. So again, to make a long story short, I said, what does the primary care want to do about your loss of smell? And her response was, she said, I have to live with it. Well, folks, this is not normal, okay? And this is pre-COVID, so it certainly was not normal. So what would you think about if she had a normal MRI? Well, you were doing 3 millimeter contiguous cuts through the skull, through the head and brain. You're going to miss something if she moves. And sure enough, she had an MRA and she had a pretty large MCA aneurysm, and to the point where Dr. Grady down at Penn said, this is very significant. She says, well, am I going to see my granddaughter's graduation this weekend? He said, if this ruptures tonight, you're not going to see tomorrow morning. So she was coiled and she's doing really well. And you can see the distribution here where on, the middle cerebral artery is about a quarter of your patients that have an aneurysm along the circle Willis. That's where it's going to be most significant for these folks. And as soon as she had her aneurysm coiled, within hours, her sense of smell came back. So, again, we could go through the anatomy here, and Joe can certainly explain this better than I can, but, these are very vital areas to the brain. And if there's an aneurysm, if it happens to rupture, a good number of these, the mortality rate, as you see here on this slide, is up to 50%. And anything in between 7 and 10, and if it's greater than 10, they've got greater than a 1% chance per year of having a subarachnoid bleed. I had a lady who came in about 5 years ago. She said, I think I have a retinal detachment. She came in and we did a quick screening field on her with a Humphrey. And she had Welsh Allen, we did a quick screening field. She had a homonymous defect. And I said, wow, and you've got a headache? She said, yeah, I heard this big bang in my head about an hour and a half ago. I said, here's your script. We're not going to do any more with exam. You go down to the emergency room and tell them what I'm concerned about. Well, she went down. I checked on her the next day and she was in intensive care because she had a ruptured aneurysm. So thank God we got her out quickly. It's very important to get them out in a timely fashion. You don't want to sit there and do a 3-hour exam on these folks when they need to get to hospital right away. So she should have been in the hospital rather than our office, but nevertheless, she thought she had a detachment, but she had something much more significant. To give you the sad news, she passed away about a week later because she didn't survive. She was 86 and her caregivers did not want any interventional surgery, sadly. So,
Joe, a private question to me just came to me.
Sure.
MCA, what's that abbreviation stand for?
Middle cerebral artery.
Thank you. Yep.
So if you look at the size of aneurysm, that's going to determine probably what technique you're going to use. If you're over the age of 60, that should say under the age of 60, anything greater than 5 millimeters is considered significant. Anybody else, regardless of your age, if you're up around 10 or higher, then that's significant. And pipeline embolization is a fairly new technique from Hopkins where they use a flexible stent and that may cure by clotting. So depending on the size and location, it's either a thin neck coil or a thick neck clip through the skull. But now this pipeline embolization technique, I think, is being done elsewhere beyond Hopkins. And here you see a schematic or cartoon of the two most often used techniques, at least in Northeastern PA and probably in Philadelphia as well. So what is this? You know, what are we looking at here in this center? This was actually sent in for a diabetic who they thought had neovascularization. Well, this is not neovascularization, but this is Weber-Landau syndrome. And this patient is the one that we talked about that had a significant, did a brain MRI because she had a significant AV malformation. So that's something that's being watched on a pretty regular basis by her neurologist. You can see the same thing, these kind of raspy lesions or vascularizations that could signal something else, not just in the eye, but also the brain as well. So those folks need to be imaged. I think when Mark Dunbar was on, he talked about Purtscher's retinopathy. For anybody who was on that call, I talked about, you know, the significance of these lesions are quite devastating, especially in this particular patient. This one case is a 57-year-old that came in and she had, again, just flashes of light, and we dilated her and took a look at her various infarcts, typically bilateral. You can see she has some on both sides, but especially the right eye. These are multiple infarcts. And, you know, you have to worry about a whole host of things. And here you can see her, you know, late stage fluorescein with ischemic changes, but look at these numbers off the wall. And unfortunately, she had pancreatic cancer and just survived only about 3 months, which is not atypical for pancreatic cancer. But look at these numbers, how significant they are. She was on her way to see her gastroenterologist and also an oncologist, but we got these labs on her before she went over, and you know, it was just a sad diagnosis for her. Our most recent one is only about 2 weeks ago. A patient had a knee replacement and inside, usually it's long bone trauma, but it's also been reported in just simple hip replacement or knee procedures. She had, this is her picture here. Oops, sorry. Okay, this is really the mechanism where you get complementing amplification endothelial injury and you get that leaky vessels. But total knee replacement, this is a case report of 2. I don't see the date on here, but you know, it's not that important. But just to know that this person, we worked her up to the hilt. Primary care physician was not too interested because she didn't know what Purtscher's retinopathy was. But we said, look, this is, you know, she's got a leaky disc. She's got all these infarcts. We're worried about her. So, you know, her casual systemic workup, sometimes I think you have to be their primary care physician. And the only thing we're coming back with on her is that she had a pretty high SED rate. We were ready to do a temporary biopsy, but our neuro guy overruled us. And I think that was the right decision because she had knee replacement 2 weeks prior to coming in. And here's her picture. Here's what you look like, both eyes. Not the best picture, but you get the idea of what it looks like. And here's her fluorescein where it shows some leakage of her disc. They can be quite dramatic. Here's a patient just from the literature that had carotid artery dissection. And this is what the clinical picture looked like. It can be, typically it's both eyes, but this would be one-sided. Here you see again on OCT, OCTA, and the fluoresceins are very dramatic for ischemic changes. So the highlights would be, again, the majority of these are going to be bilateral. As I chatted in, the Purtscher-Flecken or pathognomonic pretty much, pathognomonic for this disease, or we could call it Purtscher's-like retinopathy. In OCT, you got a hyperreflectivity in middle maculopathy as well. But there are no accepted treatments or recognized treatments. There's really no benefit to corticosteroids. Although I will tell you this, that, you know, a wise person once said that nobody should go blind or die without first having a course of steroids. Now, she's not going to die from this, assuming she doesn't have pancreatic cancer. Unfortunately, her GI enzymes and her pancreatic enzymes were normal. So we're really blaming it on her surgery, and she's due to have the other knee done. I don't know how she's going to proceed with that. We'll see. I just threw this in the last couple of days because this is our first case just recently of COVID retinopathy. This is an artifact up here, this white thing. But if you look closely, you'll see some edematous retina. You'll see these little hemorrhages, intraretinal hemorrhages. And this is a patient that was COVID positive who said, I've had some vision changes over the last couple of days. I like this discussion because the OCT has allowed us to make, you know, some very significant diagnostic decisions, even to the point where we're naming things after what we see on the OCT, especially in particular paracentral acute middle maculopathy. And this is a patient that had an artery occlusion, could be any vascular occlusion. You see in the center here, this whitened area, and that's called middle maculopathy on OCT. It simply just shows that the patients had some type of occlusion. Two different types, and this is probably, you know, a variant of a novel variant of AMN, which is acute macular neuroretinopathy. Neuroretinopathies are really interesting because there are only so many things that will cause that. We, not too long ago, had a patient with Bartonella who had a neuroretinitis as well. So there, again, just diagnostically, just a few things that would give you that clinical picture. Here's a case report of somebody who got middle maculopathy or an occlusion in a young female with meningococcal vaccination. Getting off topic just a little bit, we had a 15-year-old last week who came in with a very classic sixth nerve palsy or paresis and nystagmus when he looked out in that direction. What's interesting, because he had a normal CT and MRI very quickly the day before by his pediatrician, very astutely, because that would be the first thing we'd want to get. But it turns out that he had his vaccine of J&J 2 weeks prior. And we think that's his response to, it's like a Miller-Fisher syndrome, not like it is a Miller-Fisher syndrome, which is a Guillain-Barré type response to the vaccination. So I'm not an anti-vaxxer. I had my vaccination. All our staff, as far as I know, has had their vaccination. So, but this is interesting when you talk about vaccinating 15-year-olds and, you know, what they're seeing with heart and everything else. This patient had a Guillain-Barré-like Miller-Fisher syndrome from, we think, from his vaccination. We need to worry about ocular cancers. This is a patient that had an acute sixth nerve not too terribly long ago. Relatively large soft tissue mass in the left parietal region surrounding that mass effect on MRI. And our first clue that there might be something going on here from an ocular standpoint is just all this schmutz that she had, this very significant vitreous cell layers, large cells. These typically are B cells. What's interesting is you don't get really a great return on a sensitivity standpoint with simple PCR testing, or serology, I should say, cytology, because it's only about a 30% sensitivity. So you need to combine it with looking at PCR testing and flow cytometry. As you see here, there's a big elevation in comparing LL to 10 levels and interleukin 6 levels. So again, typically a B cell lymphoma in these patients, but here you see the medications, treatment with even radiation, bone marrow transplants, but you know, full, you know, sometimes full body radiation as well. And again, this is just an article showing the biomarkers with that ratio, light chain ratio, way off target between IL-10 and IL-6 is pretty diagnostic. Intravitreal methotrexate has been used to salvage therapy if all else is failing. So keep in mind, you don't want to miss these. Here's what her view of the optic nerve looked like, because all that schmutz that she had in her vitreous, tried to get an OCT, and this is what it looked like. This is before we actually even looked inside the eye, got an OCT after she was dilated. And then on her vitreous tap, you can see the cells that are accumulating there, in particular B cells, suggesting that this is ocular lymphoma. So sadly, the survival rate is only about 41%. If they have a mantle cell lymphoma, it's only about a 5% survival rate at 5 years. So this is not good statistics for these folks. You need to think also about CNS involvement. She had a sixth nerve involvement. So 25% of patients that have ocular lymphoma, vitreoretinal lymphoma, will have some CNS involvement, including nerve palsies. But if you have a CNS involvement, probably about 20%, or I'm sorry, if you have CNS involvement, it's about 25% ocular involvement, and vice versa. If you have an ocular involvement, it's about a 90% CNS involvement. So it's very staggering. It's quite lopsided looking one versus the other. So we're going to shift a little bit to suspicious lesions. And I always like to start by saying, I'm going to share some cases with you. And for the last 18 months, these are at least 5 cases, maybe more, that we sent down to Wills, and they were ranked number 2. Bascom Palmer, of course, Joe, down in your area. Bascom Palmer is always ranked number 1. I'm not sure who does all the ranking, but Bascom Palmer seems to always edge us out. But the last year, Wills was number 2, primarily because of their oncology department, and in particular the Shields, who've done just a tremendous job, and we're so lucky to have them so close to us. But I would say that if I have 5 cases here, and I think I do, out of the 5, there were 2 that I was absolutely, positively sure they were melanomas. And Carol said, no, these are not melanomas, but I'm going to see him back in 6 months. If she wants to see him back in a year and let me see him in 6 months, then I'm not too concerned about it. But when she says, I want to see them in 6 months, that means she's pretty sure, but she's not absolutely positively sure. And these two, I'll show you why. I was guaranteed, I would bet the house on it that they were melanomas, and she came back and said, nope, not melanoma. Out of two of them, out of the five, two more, I would have said I could go either way on these. And one was a melanoma by her identification and the other one was not. And then the one I almost didn't send down, and I'll show you why. I almost didn't send it down. She said, this is a very, very thin melanoma. So thin she couldn't get a biopsy on it, but she's treating it as if it's a melanoma, and you have to take her word for it because she's the expert. So, you know, the mnemonic is to find small ocular melanomas and its thickness, fluid. You're really looking at symptoms, flashes of light in particular, like that one patient I was talking about, this orange pigment that can really be a tip off, as well as the margins. And then, you know, the other thing is, you know, looking at the hollowness or ultrasound, and we'll show you some pictures in a moment. And I want to thank Carlo Polino. I don't know if Carlo's on tonight, but he sent me some nice slides. And if you've seen his lecture, these are really taken from his lecture, and I'll point out which slides they are. But A scans and B scans can be very helpful, and they like to do enhanced depth OCT, which can be extremely helpful, as well as autofluorescence. So let's take a look at a few cases. Here's a B scan where these are acoustically quiet, but you can see the excavation up there on the top, very significant, very thick, large melanoma, kind of breaking through that area. And then on A scan, low to medium internal reflectivity down here at the bottom, is you can see that very easily as well. This orange appearance is classic for highly suspicious for melanomas, and I'll show you our slide here in a moment, but this is our first case. This is a patient who came in who had photopsia. She had flashing lights. Not overly exciting here, but there's, you know, a lesion right here close to the macular area. Remember, this is about, the foveal area is about the size of a pen tip, and then you're out about 5.5 millimeters beyond that area. So that's not very large, but you can see over here, a little bit of interesting features to this. And here's what bothered me the most. There was fluid. So part of the mnemonic is if there's fluid, we usually send them out immediately. And this is underneath the retina. But you can see that, you know, everything else is pretty much intact. She had absolutely no complaints, but because she had that central lesion, I said, let's just get an OCT. And sure enough, she had fluid. And this is one that I thought, yeah, this could be a melanoma, one of them, but I would go either way on this one. And she said, no, this is not a melanoma. But look what happens when she comes back in a year later. What's going on here? This is the same patient. She had that choroidal lesion underneath the retina in the choroid. Okay, what's happening here now in the intraretinal areas? It's got some fluid, a little bit of subretinal fluid, but a lot of intraretinal fluid. She's got a secondary membrane. So she has neovascular macular degeneration. So she's now getting Avastin injections. And the concern you have to have is, I'm going to have to look for a reference, but I once heard a person say, you know, the anti-VEGF medications probably are not the best thing for suspicious lesions because they may enhance, if it is a melanoma, the growth of the melanoma. But they get them all the time after they're radiated because they have retinopathy from the plaque radiation. So they have to get Avastin or Lucentis or Eylea. So this is a person that's been treated now for about 6 months for her subretinal neovascularization, which is broken through here and it's pretty extensive. Here's my tech's wife. I won't tell you her name, but this is one that I would have bet the house on, that I had said, this is definitely a melanoma. Look at the orangish appearance here throughout this lesion. It's a little irregular borders, pretty large, you know, not near the nerve, but pretty large, some elevation on her B scan. So more than 2 millimeters of thickness. This was one that I would have bet the house on was a melanoma. And this was like 2 years later now, because there's fluid. Look down here in the bottom left, you can see, and I think I have an OCT picture of her. Yeah, look at her fluid. She's got a little schisis through the center there. So this one is one that I would have bet the ranch on, that this was a melanoma, and they're saying no, and they've watched her once a year, and I see her once a year. So every 6 months she's being checked. Okay. Now, here's the one that I would have said, gee, should I send this down or not? And if you look at that, how many times have you looked out in the periphery and said, gee, that looks pretty speckled, doesn't look too exciting to me. But really what got my attention is look down here on the left. He's got some fluid in the macular area of all places. This is not even close to the macula. This is paracent, or this is out in the periphery, mid-periphery. But look at the fluid down here at the bottom. I think I've got a picture of it. Sorry. There we go. Look at the fluid he has here on OCT and on just red-free. So I thought maybe that was just simply an hemangioma. We sent it down and Carol said, I can't get a biopsy, but I'm going to treat it as a melanoma. I think this is a melanoma. Fortunately, all his oncology visits have been completely normal. He's doing really fine, but he was plaque radiated. He just got radiation for what she thought was a melanoma, and who's going to second guess Carol Shields? So this is one I said, wow, am I glad I sent that down? And I got to be honest with you, if there wasn't fluid there in the macular area, I'm not sure I would have sent that down. I certainly would have watched it, probably instead of saying come back in a year, come back in 4 months, 6 months at the most, and we'll take a look at this thing. But it was too thin and too flat to even get a biopsy. So, okay, I'll do one touch instead of two here. This is courtesy of Carlo, and this was in his lecture, but the classification now on tumors, class 1A, the prognosis for these things are pretty significant. If you look at class 1A tumors, very low risk of metastatic disease, about 2%. However, if you're the Bascom-Palmer classification, class 2A or 2B, you've got a 72% at 5 years to have metastatic disease. So not such a great prognosis with that type. And they're doing a lot of different genetic markers right now, and some are more favorable than others, but getting a lot of good information on what's happening. Again, courtesy of Carlo, you can see these metastatic lesions down here, these little gray spots in the patient's liver. Anything greater than 2 millimeters, flashes of light, proximity to the optic nerve. Remember, the optic nerve is the front of the brain. So if you're going to have something, in the back of the eye that's close to the optic nerve, there's no better way to have that spread than through that particular vector. And at 15 years, there's about a 50% chance that these patients are going to have metastatic disease. We've been pretty lucky. I mean, the last 4 or 5 cases I've had, some of them are out 15, 16 years or beyond. But we have lost 1 or 2 patients that I've had personally in the last couple years. If you look at metastatic disease, again, the most common type of cancer in the posterior pole, these tend to be kind of yellow amelanotic lesions. And at the time of diagnosis, about 25% of these patients will not know they even have cancer. Women, possibility for bilateral disease. You can have that with men too, with lung disease, but the primary tumor for women is certainly breast cancer. You would think maybe a prostate, but for men it's lung. Close second would be prostate. But again, looking at these things from a mortality standpoint, not just the morbidity, is really the key here, because what's the long-term prognosis when you see one of these lesions? This is a friend of mine, unfortunately, and he passed away about 6 months ago, but I saw him for a routine exam. He said, by the way, I've got a little spot in my vision, and you can see below this yellow amelanotic lesion, which is slightly elevated, about the size of the optic nerve, so not very big, probably close to 3 millimeters, not much more than that. He's got this big area of edema, and here's you see what his OCT looked like. He had metastatic disease because he had sarcoma. This is mostly, but he had lesions in his brain when he had an MRI, the whole bit. So they treated him with PDT, and his spot in his vision went away. You can see the resolution of fluid underneath the retina that just went away with PDT. So, but unfortunately, he just passed away probably about, well, just a little over a year ago, I guess. This is a patient we saw in the last 5 years that had esophageal cancer, and you can see the multiple amelanotic lesions that really encompass a good part of the posterior pole. So you really want to be careful anytime you see these lesions, that you really have somebody take a closer look at them and just do a detailed history on the patients. Here's another one, lots of fluid. This is a metastatic breast cancer patient. And I include this because this is not so much life-threatening unless they have a paraneoplastic syndrome or workup, but this patient turned out to have Lyme disease. Again, it is absolutely unbelievably prevalent in Northeastern PA, as Greg can tell you the same in probably Western PA. This is a patient that has acute exudative polymorphous vitelliform maculopathy. That's a mouthful, abbreviated as AEPVM. And you can see here's lesions. These are very interesting to look at because they have serous fluid with pigment epithelial detachments, these multiple focal lesions throughout the posterior pole. And as it turned out, we did have him worked up for paraneoplastic disease, but he had Lyme disease. Here you can see a color photograph, which is a little bit more interesting to look at. Okay, so again, rare etiology, kind of unknown, idiopathic. Symptoms depend on, really what you see clinically as well. And most importantly, the big differentials are listed there at the bottom, which we alluded to. Probably a close second to one of my most interesting cases, but I'll call it a close second. This is a 27-year-old that was donating plasma twice a week. So what's wrong with that? Well, she was making $500 some every time she donated, and they weren't allowing her to do it except she'd go from one center to another. So she was able to do it twice a week. And from each center, she said she made $4,500 a year. So you're supposed to be able to track these things, but she was donating plasma twice a week. And the one day she went in, the nurse said, your blood pressure is incredibly low, but we're going to go ahead and do this anyway. And within an hour, she called us and said, I've got this blind spot in my vision, kind of off center a little bit. And you can see what her clinical picture looks like. She's got this fibrin clot. She's got a branch artery occlusion. And you can see it over here on red free, just very, very classic, just a nice little fibrin clot down here at the bottom. Well, fortunately for her, she's young. She responded pretty well. But plasma donation should not be more than every 2 to 4 weeks with a maximum of 12 times a year. She was doing it twice a week for probably the last 2 or 3 years. And platelets, you can actually, surprisingly, you can donate those, but probably much on a 7 to 10 day basis, but no more than 24 times a year. But because she was donating so much plasma, she had this paradoxical feedback loop where she, this is kind of a platelet driven disease. She's got a clot, fibrin clot there, which fortunately with her age, she's left with a little bit of pallor up here on her disc, but you can see how she cleared within just a matter of a few weeks. She's still left with this small little spot in her vision, which really is probably, she has that to be thankful for, that she didn't have anything more serious. So you got to be on the lookout for these folks. She worked at McDonald's. She wanted to make a little extra money, and you can't blame her for that. But various etiologies, and we'll talk a little bit about the significance of artery occlusions, especially since most are embolic. But there are other reasons for artery occlusions, and here you see at least a partial list. So part of the exam would be to make sure their blood pressure is okay. You want to do lipid levels. If they're over 50, you certainly want to get a CBC and platelets, ESR, C-reactive protein. But I think the lipid panel is very significant as well as a fasting blood sugar on these patients. And of course, you want to work up their patients from a vascular standpoint, which would include, probably a transesophageal echo if you think it's within your purview to order, but certainly through the primary care physician to have some discussion with he or she and look at the carotids either with a CTA or perhaps just a simple ultrasound. So we're going to launch the second question. I'm not going to give you a hint, but I'll tell you what the topic is in just a moment. So we have a couple like in fast order here. So we talked about doing a C-reactive protein and an elevated SED rate. What are you looking at in particular with a CBC on patients over the age of 50 to see if there's any elevation of this particular portion of their CBC on, and you have to specify that you really want to look at this too, because I'm not going to say any more because I'm going to give it away. So we'll let you vote. And again, you can say not sure. Hopefully after this poll is launched, we'll have an answer for you.
And just so you know, Joe, there's no other questions in the chat box. And
We may be putting people to sleep here.
no, I don't think that's I don't think that's what's happening. Dr. Barbara Horn wants to know if schmutz is an actual medical legal term.
Schmutz is a definite medical term. We've coined that in honor of our corneal specialist, who everything he looks at is schmutz. Blobs, strands, whatever you want to call it, I guess. Okay, very good. So we have over 50% with the right answer. And again, you could say some overlap here, okay? But really we're looking at platelets. If they have an elevated platelet, you worry about kind of an, again, sensitivity toward giant cell. And here's our article that would help you with that. So courtesy of Hey Ray and Surgott and his group have talked about this as well, where the role of thrombocytosis which would be increased platelets in the diagnosis of giant cell versus thrombocytopenia. You really need to really take a close look. It's just another piece of information that will help you decide whether that patient really needs a temporal artery biopsy or not. So the big difference.
So Joe, let's review all that just so the audience has that. Is that you're going to do a C-reactive protein? I'm sorry, you're going to do a C-reactive protein. You're going to do a complete blood count, and on that, you're looking for hemoglobin to go down, but you're looking for platelets to go up, and then SED rate. So if there's kind of the four things that are out there, CBC, and just as you talked about, elevated platelets, but hemoglobin down, C-reactive protein up, and SED rate up. And then we'll talk about, maybe Dr. Salko will kind of talk about the hospitalization.
Yeah, generalized anemic state. These are
right.
Folks, this next couple of slides, Joe, if you can hold your comments just for a second, because I want to just kind of pontificate a little bit on, do we send these folks with artery occlusions to the emergency department or not? And it's kind of the taste great, less filling debate. And not to scare anybody, but let me tell you the most recent example I have. On a Friday afternoon, of course, about 4:30, this individual comes in from the cardiologist's office. Now, he's a vascular path. He's just seen his cardiologist. And he's got this spot in his vision. So he comes in and he's got a classic artery occlusion. So I begged him to go down to the emergency room. I said, you got to go down to the stroke center because I'm just worried about you. You've got your vascular path, you've got to go down. There's about 25% of you that are going to have acute brain infarction. So you might have a major stroke. This is a stroke in the eye, so you need to go down. Well, he gave in. His family convinced him he should go down. I checked on him the next day, and the nurse said he had a massive stroke at 2:00 in the morning. Can you imagine if I sent him home on a Friday afternoon and said, you're going to get your carotids checked, you're going to get your blood work next Monday when you go to your primary care physician? Can you imagine if I sent him home and he had a massive stroke at home? Not to mention what's right for him, but from a medical legal standpoint, they tubed him right down to Hershey Medical Center. I haven't seen him since, but I hope he's doing okay. But just from a medical legal standpoint alone, especially if there are any neurologic symptoms on these folks, you need to get them out. And when in doubt, just get them beyond the primary care physician. I would send them, because if it's a Friday afternoon, the primary care physician is typically going to blow them off. If you've got a stroke center around town, hopefully you do, or even to the emergency room where they should be capable of doing the needed test, just tell them, look, here's the blood work I need. This is what we're worried about. While he's there, can you check his carotids? Maybe they'll do even an echo on him. But these are very, very important aspects of treating these patients. So, and don't forget to bring them back, because the complications on these folks in a relatively short period of time would be secondary neovascularization and glaucoma. So they really need to be followed fairly closely. But we are a big fan of doing DWI imaging on these patients, because you don't know if there's the 25% that don't have a brain infarct or the 75% that may not have a brain infarct. These patients need to be evaluated, especially if there's any other neurologic symptoms. Joe, happy for any comments that you may have.
No, I agree with you entirely. You use the phrase stroke in the eye. I can tell you right now that I was helped out trying to get a paper pushed through and endorsed by our academy. The American Heart Association is now going to be defining central artery occlusion as stroke.
Absolutely.
Not stroke in the eye, stroke.
Yep. That's my next slide, but absolutely, that's updated definitions are certainly, this is a stroke, folks. Basically, that's what it is. So, and again, if your comfort level, you certainly can talk to primary care physician, but don't let them be lax about it. You need to be the patient's advocate, because here you see the statistics, okay, they're kind of sobering. This is a series of 103 patients. 37% showed significant carotid artery disease, 33% hypertensive retinopathy or emergency hypertension. And then at the very least, these patients needed some change in medication the majority of time. So, don't be a hero. Again, as Joe mentioned, this is, the definitions that we're looking at. This is a little bit dated. It's the ABCD scoring features. Those of you that are not familiar with it, they're looking at risk factors for TIAs in patients having a follow-up stroke. If they're over 60, they get a point or two. It's behind Joe's picture. I'm not sure how many points they get. If their blood pressure is over 140 over 90, they get a couple more points. Clinical features of TIAs, especially if there's unilateral weakness, they get another couple points. Duration of symptoms, you can see higher values for longer periods of time, and a history of diabetes. And that would give you a cumulative score, A, B, C, D, age, blood pressure, clinical features, duration of symptoms, and then of course, diabetes. So for what it is, it's something you may want to look at from a risk perspective. Again, probably more suited for the primary care physician.
Hey, Joe, let me step on you again here. And where I was going with this GCA is most of the patients going to come into our office are going to be on an older GCA for a central retinal artery occlusion. And we really don't have to really do the blood work, or at least I don't, and that's my opinion. And I just send them right over to the stroke ready hospital for the fact that if it is GCA, what's the best place for them to be? I used to do all that blood work and point out all those 4 points or 4 parts of the blood work. But now if they come in with a central retinal artery occlusion and I'm not suspecting it, it still could be GCA. And what's the best place for them to be is at the stroke ready hospital. So that's, when these patients come in, that's kind of what I've done over the last, central retinal artery occlusion, branch retinal artery occlusion. Valerie Bois and Joe, help me out, Nancy Newman. They're out of Emory, and they're the ones that are kind of leading the way. And I'm just kind of being a disciple of that that's out there. So just, anyone that's out there, to me, central retinal artery occlusion, I've had it happen where they, just like Dr. Shovlin had, patients having strokes, heart attacks in the hospital, and luckily they were there at the right place.
And there's a lot. I'm sorry, go ahead.
I was going to say, Joe, you're going to like the question that's in there. I'm going to let you take it. And the person didn't say brown. I'll let you run with it. It says, do you have them breathe into it doesn't even say paper bag. It just says, do you have them breathe into a bag? So I'll let you run with that one.
What's Joe?
Go ahead.
Joe Salka.
No. The answer is, I find generally no. The most important thing is to get them to the stroke unit, and not to the retina specialist either, because there's a lot of pushback from retina. A lot of them are not familiar with this. They don't know about the association. Some are pushing back against neuro-ophthalmology and these recommendations. Some are coming around, but many are not aware of it. So don't send to the retina specialist. Don't try to get the imaging yourself. Get them to the stroke ready hospital and tell them what you're looking for.
It's always the golden hour too. I mean, we've done paracentesis, we've stuck needles in eyes. I don't have anybody that I'm aware of that we've been able to really recover vision for these folks. So you can do these really heroic measures and it doesn't really do a whole lot. So here's an interesting.
Joe, let me clarify where I wanted Dr. Salka to go with the paper bag thing, was that we were all taught in school that it was supposed to be a brown paper bag.
Right.
And so, Josephine out there, yeah, you are correct. I was taught the same thing. Do we have them breathe into a paper bag? The answer is no. You just send them right to the stroke ready hospital. I was taught that. Dr. Shovlin was taught that. And so was Dr. Salka. But it was always our joke behind the scenes was it had to be a brown paper bag. It could or brown paper bag.
No other color.
No other color. Yeah. Right? No other color. It had to be brown.
Yeah.
But we were all taught that. We don't do that.
Not a saran wrap baggie. Yeah. So yeah, we're just dating ourselves here now. So this is a nice article looking at OCT in the unilateral eye, on the contralateral eye, with unilateral artery occlusion and the thickness differentials in the fellow eye. So I thought that was very interesting. And then again, this is really a kind of a fascinating article looking at not causation, but associated effect. You got to worry about post hoc fallacy. Just because event B follows event A doesn't mean event A caused it or is a precursor to it, but they're looking at occult cancers in patients with ischemic stroke. So very interesting how they're tying things together here. So let's get our third question. We're gonna have to move quickly here, guys. So we can bring up that third question so we can get to the fourth one. The most likely cause of retinal macroaneurysms, again, this is part of the life-saving signs or symptoms. What would you really want to worry about? There are a lot of different things, and maybe all these are correct, but which is the most prevalent in an 80-year-old with a retinal macroaneurysm? We'll give you just a few more moments to respond to this so we can get to the last question. Greg, can we launch that, or is that you need more?
Just one. I'm just we're at about 74% here. So I just want to
Okay.
get it up a little bit higher. And then we'll end
Take a
it.
wild
Joe,
guess, folks.
and you're doing well with time here. About the time I started with the housekeeping, we want to go about 8:55 or 8:45, 8:50. Sorry, not 8:55, 8:45, 8:50. So.
Okay, very good. That's the right answer. We'll show you the stats here. I think it's about 75% if I'm not mistaken. This is our patient. This is near and dear to my heart because this is my mother-in-law. You don't know her name for HIPAA violations because it's my wife's mother. So you can see very significantly, superior temporal area is probably the most prevalent area for these. Typically at the AV crossing or arterial bifurcation, they can be saccular in appearance of fusiform. And here we'll show you again, 75%, yeah, systemic hypertension. But the other things are important. These are risk factors, of course. So let's look at certainly differentials in the types of different treatments, including we offered her surgical evacuation and tissue plasminogen activator, TPA injection. She opted for none of the above. And here you can see what it looks like. These are little saccular white lesions. These are the macroaneurysms, and you can see that all assorted different types of hemorrhages, pre-retinal, intraretinal, subretinal. And you can see two of them there on these whitened areas. So this is what it looks like an OCT. It was actually both eyes. Here's the other eye, the left eye we showed you first. And bilateral is a little bit unusual, but with hypertensive changes, you can see some at least subtle hypertensive changes here. And here's before and after. This is with no treatment, it's about 2200 vision or less. Over here, about 2040 treatment on the right after about 3 or 4 months. So, if it was me, I think I would have tried something heroic, but for her, it turned out just fine. And we know the ravages of hypertension. We move these numbers down, still considering under 120/80, diastolic being normal, pre-hypertension, anything over 80 to 89. So it's kind of like pre-diabetes now. And some of this is driven by pharmaceuticals. Just like I can remember when I graduated, a 300 cholesterol was considered normal. Now, if you're not 180, you're dying. Depends on your breakdown of the cholesterol levels, total cholesterol. But again, stroke, heart disease, certainly important. I'm going to go through this quickly because I want to point out what gas plaques look like. And this is a patient that has hearing loss and artery occlusion in Sussex or Sussex disease. We had one of these that we sent down to Wills for confirmation with a diagnosis, and the fellow in the neuro-op department got real excited and wrote it up as if it was his case. So we were a little bit livid that we weren't included in the publication, but nevertheless, patient was treated appropriately and managed. And it can be misdiagnosed on MRI for NMO or multiple sclerosis or even encephalomyopathy, but it's just a completely different clinical picture. Can't see, can't hear. Bob Surgott refers to this as a marital problem. You can't see, you can't hear. And that's, of course, a joke. But again, the big thing is making a differential between multiple sclerosis. Gas plaques, we'll show you what they look like here in just a moment. Here you see his retinal hemorrhages, which are quite deep. And these little finger-like projections are what they call gas plaques. And that's pretty much pathognomonic for Sussex disease. Some heroic measures with IVIG infusions, more and more with IVIG, with myasthenia gravis, with all sorts of immune-related diseases, CellCept, Imuran, these things are all tried with some success in patients with Sussex. So let's go to the fourth polling question. I won't give you any hints on this one, but it's our next topic. And PFOs, or septal wall defects, commonly have associated what? History of migraines, Barlow's syndrome, dental disease, scleroderma, and not sure. That's why I'm here. I'll give you a little hint. It's a diagnosis by exclusion. And we're going to speed through the next few slides so we can get to the summaries and again, you have the handout, so I'm not going to read all these things to you. You can go back and review them, and feel free to send an email. Okay, history of migraines. So you guys are 100%, I think. Nope, actually down at the bottom, not sure. But anyway, those that responded with one of the 4 options, it is history of migraines. Okay, let's go to the next slide. Visual disturbance from PFO. And this is near and dear to my heart because this is one of our associates who had a spell in the office. He went to the hospital. The cardiologist was in and said, your heart's fine. But the neurologist came in and followed up later. He said, you know what, let's get a TEE on you just to play it safe. And he had this huge septal wall defect. And it's amazing he didn't have a stroke prior to 63. But especially if you got a younger patient that has a cryptogenic stroke where there's nothing on their scan, you need to be concerned that they may have a patent foramen ovale or septal wall defect. So again, the causes of transient vision loss. And again, we talked about amaurosis being an ocular etiology, which is a subgroup of TIA, but TIAs in particular with transient vision loss would be more of a cerebral type, and lots of causes here. But I want to get to the subject at hand. I've included this because here's a patient that we saw that had a stroke about 1.5 years before. You see that, and this is again the right side of the brain, the arrows pointing to lesion. You should order all scans with arrows pointing to the lesion. Unfortunately, the radiologist won't do that for you, but if you order a scan, you own it. So you got to be able to look at them too. So look at the cortical lesion, look at the GCA 1.5 years later. That's a hemianopic defect on the GCA. And this is a retrograde effect all the way to the retina from the back here, back of the head, all the way up to the retina. So that's a hemianopic defect in a patient that has stroke about 1.5 years prior. So that's just incredible what we're looking at these days with OCTs and beyond. We're looking at metabolic OCTs coming up, and I think that's just phenomenal. So if you look at septal wall defects, there's this paradoxical shunting on the upper chambers where the blood is not filtered through the lungs, especially with the patent foramen ovale, it puts them at risk for stroke. If you look at just in general, 25% of the population does have some form of septal wall defect, but they're minor. If they're not bad, you can put them on aspirin, but who wants to be 25 years old and on aspirin or blood thinners for the rest of your life? 87% of strokes are ischemic. That means 13%, or some numbers are showing higher, up to 15, 20% are hemorrhagic. And if you look at 30% of these being cryptogenic, they don't have any signs on their MRI. And especially if they're younger, you have to look at their heart and make sure they don't have a PFO. So I think this is really, really important. I've had about 2 or 3 of these in the past year. In young patients who've been in the hospital, nobody took the time to ask them if the cardiologist saw them. And it's really, really important that they see a cardiologist who's attuned to PFOs. So you can see the numbers are quite staggering. If you look at the general population with migraines, it's about 16% of women and probably 8% of men. So it averages out about 12%. 50% of people that have migraines have PFOs that are significant. 50% of people with migraines have significant PFOs, and that may be why they have these migraine events. I'm not suggesting everybody with a migraine has a PFO, but it's kind of staggering. Even if they have a PFO, it may not be that significant. So looking at risk, especially in women with migraines, visual Rs, and other risk factors, I tell them to see a cardiologist, and some of them blow us off and some of them do the appropriate testing. So you want to avoid significant strokes. I know in England, they wouldn't do a TAVI procedure, close the septal wall defect with Dacron, unless they had a second stroke. Can you imagine you had to have your second stroke before they give you something other than aspirin or anticoagulants? Here you see the infarcts on the brain scans on the number of patients that have PFOs. Here's our patient. This is our associate. You don't have to be an expert in reading transesophageal echoes. You see that flap moving there. That's their PFO. Over here is after Dacron closure. Much better. So the patient's doing really well. So let's take a look, see if we can move on to the next slide. You can do transcranial Doppler with injections where you don't have to have them swallow this thing and sedate them to do a transesophageal echo, because regular echoes are not that sensitive. They're okay, but they're not that sensitive. You get this curtain effect, which is very, very diagnostic for a PFO. So closure is the way to go. I think in most cases here you see a procedure where they come in with a TAVI procedure to close that septal wall with a Dacron patch. That's one. Here's another patient. This is actually our associate here being done, and very, very nicely done by a local interventional cardiologist. So again, the goal here is to minimize the potential for stroke. And again, I think we've covered this ad nauseum with the potential association between PFOs and migraines. A lot of these folks will get closure. Had a patient that was having constant symptoms. She had closure, and within minutes, she said she stopped having the visual complaints. So I talked a little bit about criteria for scanning. Again, we said if you've got a migraine and you have symptoms, headache before, that's a red flag. Or if you're 60 years old and you don't have a history of migraines prior to 40 or 50, you really should be scanned. I'm going to just blow through these very quickly just to put out that, again, drug toxicity for cancer patients. Here's a list of things that can give you retinal toxicity. We'll talk about some of the new ones. These are new immunomodulators for patients with cancer. Here you see one at the bottom for bladder cancer, Optiva, Keytruda. These are all checkpoint inhibitors or BRAF inhibitors, MAK inhibitors. These are all very significant from an ophthalmic toxicity perspective. And they work very nicely by blocking these checkpoint proteins that really bind to other partners to prevent T cells from working in cancer patients. And it really allows the immune system to work very well. But these are kind of the intraretinal, subretinal fluids that you can get. We got one patient here was on breast cancer on checkpoint inhibitors that had bilateral artery occlusion. You see the whitened area. And again, from a cancer standpoint treatment, the neuroretinopathies, diffuse retinal vessel diseases, as well as neurotoxicities and even cranial nerve palsies that are associated with these. So be on the lookout for them because they're there. The new Plaquenil is Amuron or Pentosan for interstitial cystitis. And it looks just like macular degeneration or a pattern dystrophy. Here's one patient we saw about a year ago with what looks like classic macular degeneration. She has a maculopathy from her Amuron, and it's a dose-related response. So be on the lookout for that one because the attorneys are trolling for this very, very significantly, and you need to watch. Here's the Blenrep for multiple myeloma we talked about, where the corneal toxicities are quite significant and can be vision threatening. And some of these may be irreversible, but you see as it's designated after the first two treatments, these patients need to be seen on a pretty regular basis if they're getting this therapy. Tamoxifen, again, corneal signs as well as the refractile crystals for toxicity. Here's one patient that looked like they had drusen. These are from her tamoxifen. These are refractile retinal crystals. Galenia, we're all familiar with that. Here's a patient after 3 months of Galenia that had edema, had a little bit of uveitis as well, I think, which is probably a risk factor. They stopped the medication, she got better. And then again, I just want to bring out a point where ischemic neuropathy, this is a guy that really got religion. He wasn't using a CPAP after his first eye. This was 2009. He got some religion after his second eye went south on him, and he's now to this day using a CPAP on a regular basis. So these patients can get AFib. They can really die from sleep apnea. So they get cortical. They get really cerebral changes where they have cognitive issues. So it's very important that you stay on top of them as well. Okay, so fungal infection. This is a drug user, IV drug user. This has actually affected him because he died from a fentanyl overdose after we got his fungal infection cleared up. After many weeks of treatment, here's what he looked like. We finally got him cleared, and then 2 weeks later, we checked on him and he had died from a fentanyl overdose. So again, that certainly is life-threatening. Greg and I have these slides for the retinal ramifications or ravages from herpetic disease. Here you can see what it looks like where this patient's probably ready to detach. They've got a lot of vascular occlusions. Greg, I think this is from you with a porn. These are folks that have outer retinal necrosis, progressive outer retinal necrosis with CD4 counts that are extremely low. We don't see that much anymore though. This is our claim to fame in Scranton, PA. This is our retina guy who did a patient of mine who had Fuchs heterochromia, and he was positive for rubella. And here's our publication, Randall Pierce, Northeastern Eye Institute. We're on the map. This is the genotyping down at CDC. Right here we are, Scranton, Pennsylvania. We have the oldest typing of rubella from Fuchs heterochromia in the world. And we're up here with Moscow, with Beijing. Scranton, PA is also famous for something other than the office. It's noted for its rubella case. And the last thing I'm going to share with you is a patient we just saw this week. She came in because she has, by definition, apraxia upon eyelid opening. For those of you who don't know what that is, they wake up in the morning, the one lid is down. They lift that lid on their own. This is not myasthenia gravis. This is first thing in the morning. She lifted her lid and it goes up and it stays up for the rest of the day. She's concerned because both her uncle and her aunt died from ALS or Lou Gehrig's disease. And of course, we're concerned about it too, because here's why, we'll show you in a moment, but usually it's a benign condition. Here's what it looks like. They simply lift that lid in the morning and you see that's exactly what they look like after just simply lifting the lid. But 2 articles, these are case reports. They're not, again, significantly peer reviewed, but these are case reports. Take it for what it is. We're going to absolutely positively have her checked out with a neuromuscular neurologist for Lou Gehrig's disease. And hopefully she doesn't have that. So what I'm going to do is just have you read these on your own because we're at the end of time. I think just a few bullet highlights is you order a scan, you own it. So make sure you have the ability to look at things. We talked about something I didn't talk about is bilateral fluid could be reduced albumin levels in lupus. I didn't throw that in, but somewhere we should have been talking about that. And in vertigo or dizziness with pain on the top of the head may signal vertebral basilar insufficiency. So those patients need to be checked out for that as well. And I think we've covered these in ad nauseum, but the take home here is photophobia may signal life-threatening vascular neurologic diseases, and it may be way beyond what we'd expect to see with simple vitreoretinal traction. And as I mentioned earlier, there's nothing more expensive than a wrong diagnosis. So we'll close with our last case here. And this is in case you don't know what this is. You see these little crystals in here. This is a regressed retinoblastoma. And this patient certainly would have had her eye removed 16 years ago. But fortunately, she didn't see anybody until she was 16 years of age. We still sent it down to Dr. Shields. And she said a good number of these will regress on their own. And she was fortunate. We're just watching her. She's not having any intervention at all. Unlike these retinoblastomas, which would be really interesting macular fascinations that have to be treated with either intra-arterial or intravenous chemotherapies. So, I hope sorry we've taken you to the bitter end. I appreciate your indulgence. If you want to send me a question or two, my email address is jpshovlin, SHOVLIN @gmail.com. And happy to take any questions before we close. Thanks very much.
Thanks, Dr. Shovlin, and thanks everyone for attending. Life-threatening signs and symptoms that cannot be missed. Dr. Shovlin, I've known you for years, and I sit through a lot of lectures, and every time I listen to your lecture, you blow my mind by the patients that you see and the depth that you bring to the lectures. Dr. Sockett?
No, I will agree with you. I thought that was a very in-depth and a very high-level medical approach to eye care, and I thought that was really very fascinating.
Ditto, guys. I always learn something for you too, and it's just the Mutual Admiration Club, perhaps, but you guys do a fantastic job and really like what you're doing with this educational series. Thanks for allowing me to be part of it.
Thank you.
We'll get you back on in a little bit, maybe September, October, we'll get you back on the docket here, Doc. And
Thanks.
the virtual applauses are coming in here. Excellent presentation. Thank you. That's just so you know that you can't see them, but Joe and I can see them. The virtual round of applause is coming in here.